Hello everyone, I am Dr. Vyshnavi. I am basically a ENT surgeon and a skull-based surgeon, and I am currently working in Hyderabad. So today here I am here to discuss with you some basic concepts of ENT. The first of which is understanding hearing loss. Amongst the many disorders that we have in ENT, hearing loss is one of the most common problems that you would encounter as a practitioner. So, how do we differentiate the types of hearing loss, whether it is a conductive loss, whether it's a neural loss, whether it is an age related loss, whether it's an occupational loss, or it is because of certain infective disorder? So, we should be able to understand the basic diseases which will attribute hearing loss and why are they occurring and the reason behind that and how to interpret them. So in this concise video, I will be explaining to you the basic anatomy of the ear, along with which I will be explaining you basic way in the clinic how you can test and identify if there is a hearing loss or not. So let's get started. The first thing that you would see if a patient is having hearing loss is if it is gradual in onset or is it sudden in onset. Most often, all the diseases related to ear will result in a gradual type of hearing loss. So slowly, day by day, year by year, the hearing loss goes on increasing in its intensity, and after a certain period of time, the patient really has problem in hearing. That is when they approach you and consult you to identify what is the cause of hearing. Sudden hearing loss also can occur. Sudden hearing loss usually occurs because of acoustic trauma. Whenever you are exposed to a very, very loud sound, so whenever there is a bomb explosion or there is some crackers that has been burst around the patient's ear, or the patient is working in mines or industries, because of sudden loud exposure, they can have sudden hearing loss. Also, they can have sudden hearing loss because of certain tumors which may compress upon the nerve to result in hearing loss. There may be occupational hearing loss for those who are working in certain industries, in aviation. So there may be hearing loss that can be related to occupation. And one of the commonest cause of hearing loss is age related. So age related, there is degeneration of the nerves. Because of the degeneration of the nerves and the neurons, you will have hearing loss. These are one of the commonest causes or the commonest presentations of how a patient can come to you. He can come to you with a gradual hearing loss, with a sudden hearing loss, with occupational hearing loss, or age related hearing loss. Now let's understand basic anatomy of the ear, because if you do not understand the basic anatomy, you will never be understanding what are the types of hearing loss and how this hearing loss occurs. So we have basically the ear divided into three parts. So what are the three parts of your ear? We have the external ear, then we have the middle ear, and then we have the internal ear or the inner ear. Internal ear or inner ear all mean one and the same. So what is external ear? External ear is from your pinna outside. So what you see on the outside your pinna till your tympanic membrane. This entire portion constitutes your external ear. So what is external ear is formed by? It is formed by three parts. This is your pinna. The second part is your external auditory canal. And the third part is your tympanic membrane, which we also call it as eardrum. The next part, further medially, you see another part. This part is called as your middle ear. So this middle ear is sandwiched between your external ear on the outside and the inner ear on the inside. Further medially is your inner ear. And from your inner ear, you're able to see the eighth nerve or the vestibulocochlear nerve that carries impulses to the brain. So this is how the hearing pathway occurs. It goes first from the external auditory canal. hits the tympanic membrane. In the middle ear, we have three small bones, which is the malleus, the incus, and the stapes. From the stapes, it goes to the inner ear. And from the inner ear, via your eighth nerve, it goes into the neural pathway to reach into the brain. So this is how the sound transmission would occur from your external ear till your brain. Now we classified this pathway into two pathways. The first pathway is from your pinna up till the foot plate of your stapes. Here, the sound is only being conducted. There is only conduction of sound. There is no change in the energy of sound. So this pathway is called as conductive pathway. So from the external ear or your pinna till the foot plate of stapes is your conductive pathway. The pathway beyond it, here there is conversion of mechanical energy to electrical energy. So this pathway we call it as sensory neural pathway. So the pathway beyond the cochlea is called as sensory neural pathway. So if there is a wax in the external auditory canal, it is affecting your conductive pathway and hence you will have a conductive hearing loss. Similarly, if you have age-related degeneration of the nerves, it is affecting your sensory neural pathway, so you will have a sensory neural hearing loss. So this is how you would know what type of hearing loss the patient is having depending on the pathway that is involved. So if there is any pathology that is there in your conductive pathway, it would result in a conductive hearing loss, and any pathology that is affecting your sensory neural pathway, it would result in sensory neural hearing loss. There can be an old aged man who is having degeneration of nerve. Along with that, the patient may also have wax in the external auditory canal. So those patients who have both conductive pathology as well as a sensory neural pathology, they will have a mixed hearing loss. So mixed hearing loss occurs whenever there is a patient who is having both conductive pathology as well as a sensory neural pathology. So this, I hope you've understood what are the three parts of our ear: external ear, middle ear and inner ear. What is a conductive pathway? Till your middle ear is your conductive pathway. Beyond the middle ear is your sensory neural pathway. Any disease that affects your external ear or your middle ear will result in a conductive hearing loss. Any disease that affects your inner ear, your eighth nerve, will result in sensory neural hearing loss. So this is the basic anatomy of ear and the pathways and the hearing loss. Now, whenever we are understanding the types of hearing loss, we say if there is a conductive type of hearing loss, and we also say there is a sensory neural type of hearing loss, which we have already discussed. Now, the sensory neural type of hearing loss is further subclassified into two types. It can be classified as cochlear type of hearing loss and retrocochlear type of hearing loss. So we understood what was the conductive pathway in the previous slide, but just for your revision, I'm doing it again. Anything that affects your pinna, external auditory canal, tympanic membrane and your middle ear will result in conductive hearing loss because it is traveling through your conductive pathway. In the sensory neural pathway, you have the sensory neuroreceptor for hearing, which is your cochlea. So this is responsible for reception of the sound. So if there is any pathology at the level of the cochlea, it will result in a cochlear type of hearing loss. Any pathology behind the cochlea is there. It will result in a retrocochlear type of hearing loss. So I hope you people understood what is the meaning of a cochlear type of hearing loss and what is retrocochlear type of hearing loss. So if you have a patient who comes to you with hearing loss, how are you going to evaluate this patient? In your clinic, you have a very simple instrument which is called as a tuning fork. So this tuning fork comes in various frequencies. You can have a 256 hertz tuning fork, a 512 hertz tuning fork, a 1024 hertz tuning fork. Okay, so these are the different types of tuning forks that you could have. The commonly that we use is a 512 hertz tuning fork. So you can assess the hearing in your OPD either doing a tuning fork test or by doing a procedure which is called as audiometry. Audiometry is ideally done by an audiologist, not by a ENT surgeon or by a general physician, but you should be able to understand the audiometry graphs because the audiologist will send you the report. So interpreting the reports is very, very important. So to be able to interpret the reports, you should know how this test is also done. So I will discuss briefly to you about tuning fork tests. There are two tests that we do constantly, that is Rinne's test and Weber's test. So what is Rinne's test? Now if you assume that this is your external ear, pinna, external auditory canal and tympanic membrane which we discussed. This is your middle ear having the malleus, incus and the stapes. So till here we call it as the conductive pathway. Beyond that we have the cochlea and from here goes the eighth nerve towards the brain. This pathway is called as sensory neural pathway. Now, if I vibrate a tuning fork and keep it across the pinna, across your ear, what will happen? The sound will now travel. Just a moment. The sound will now travel from your pinna, external auditory canal, tympanic membrane. It will go through the malleus, incus, stapes. It will go through your cochlea and from the cochlea via the nerve to the brain. So whenever we are keeping a sound in the air conduction route, this is your tuning fork. When you are putting a tuning fork in the air, the sound is being transmitted through the air. So this we call it as AC. AC stands for air conduction. So when you give a sound via the air conduction route, it travels via your conductive pathway and also via your sensory neural pathway, because it is going till the middle ear. From the middle ear it is also going to your inner ear. Now there is other way of doing this tuning fork test, which is through your bone conduction. So when we are doing a bone conduction test, how is the sound now traveling? When we do a bone conduction, we vibrate a tuning fork and place it over the mastoid. So when we place a tuning fork over the mastoid, what is happening through the mastoid, through the bone? The sound is going directly to the cochlea. It is bypassing your external ear and your middle ear, and the sound is now going directly to your cochlea. This is your bone conduction. So BC stands for bone conduction. So bone conduction measures only your sensory neural pathway. I think this is clear. Whenever we keep the sound in air, it goes from your pinna, your middle ear, through your inner ear to the brain. But if you keep it on the bone, it is bypassing your pinna or your external ear and it is going directly through the cochlea to the brain. Now, if you see which is a longer pathway, air conduction is longer than the bone conduction because it is taking a longer path. Similarly, air conduction is louder because the sound is heard best in air. So it is louder than bone conduction, which means AC is greater than BC. This is in the normal situation. So if I keep a tuning fork across the pinna and ask the patient to perceive the sound and say this is the first sound, Then I keep it on the mastoid and ask the patient to perceive the sound. He will, and I tell him that this is the second sound. And ask the patient to compare which sound was heard louder. Was it the first sound or was it the second sound? Ideally, your first sound is in the air, so it should be heard louder than your bone conduction. And the patient should be able to tell you that he's hearing this sound louder than the one that was kept on the bone. That means that the patient is having a normal hearing. Now look what will happen if a patient is having conductive pathology. Air conduction obviously will be affected, but will the bone conduction be affected? No, because it is not traveling through your conductive pathway at all. So what will happen? Air conduction will become lesser than bone conduction, which is suggestive of a conductive pathology or a conductive hearing loss. So if a patient says that the first sound was less louder as compared to your second sound, then it means that air conduction is less than bone conduction. Now let's look what happens in sensory neural pathologies. In sensory neural pathologies, yes, your air conduction is affected, your bone conduction is affected, both are affected, but still AC will be better than DC. So air conduction is better than bone conduction in normal and sensory neural hearing loss. So this test is called as Rinne's test, where you compare air conduction with the bone conduction of the patient. When the air conduction is better than bone conduction, you call that as Rinne positive. But if air conduction is less than the bone conduction, then you call it as Rinne negative. So I hope all of you understood what is Rinne positive and Rinne negative. Then we have another test which is called as the Weber's test. So before we go to the audiogram, I would like to describe to you Weber's test. So in Weber's test, you keep a tuning fork across the forehead, in the nasion or in the glabella or on the vertex. So when you keep a tuning fork in the midline, we have two cochleas, both want to receive the sound. So what will happen normally? Sound will get lateralized equally to both the sides if both the sides are having normal hearing sensitivity. But if there are patients who are having conductive pathology like a wax in the ear, or they are having say middle ear effusion, or they are having fixation of the foot plate of the stapes, what will happen if a patient is having conductive hearing loss? The sound will go towards the affected ear. So in conductive hearing loss, the sound is lateralized towards the affected ear. In sensory neural hearing loss, assume that this cochlea is dead. What will happen? The sound will go towards the opposite cochlea. So in sensory neural hearing loss, the sound is lateralized towards the opposite ear. So how do we do this test? So I vibrate a tuning fork, keep it on the nasion. Ask the patient whether he's hearing the sounds equally on both the ears. If he says that he's able to hear the sounds equally on both the ears, it means that the patient is having a normal hearing sensitivity. If a patient says, on keeping the tuning fork in the midline, he's saying that I'm able to hear the sound only on the right side. So if a patient is able to hear sound only on the right side or more towards the right side, it means the patient is having either a right conductive hearing loss or left sensory neural hearing loss, because in sensory neural hearing loss the sound gets lateralized towards the opposite side. So if I have a right SNHL pathology, the sound will go towards the left side. If I have a right conductive pathology, the sound will go towards the right side. So in the clinic itself, you can establish if the patient is having a conductive hearing loss or a sensory neural hearing loss. If you want to confirm, you will send the patient for audiometry. The patient will come back to you with a report. So what is there in the report? These curves are depicted in various symbols. There is an air conduction, there is a bone conduction curve, right ear and left ear. Right ear air conduction is always depicted in 0. Left ear is depicted in X. Bone conduction can be depicted by two symbols, lesser than or open bracket, greater than or close bracket. So when we see these symbols in the audiometry, we would understand what is happening to the air conduction and what is happening to the bone conduction. So before I tell you the interpretation of audiogram, let's just remember what formula did we describe previously. Air conduction means conductive pathology as well as sensory neural pathology, because the sound will travel the entire route. When you give a sound, it will travel in the air conduction. It goes through the conductive route, it goes through the sensory neural route up till the brain. Whereas bone conduction, when you keep it only on the mastoid process, the sound will go only to the inner ear. So it measures only your sensory neural route. Now, normally, what should you see in an audiogram? So you can see here the symbol is 0. 0 means air conduction curve at different frequencies, at 250 hertz, at 500 hertz, at 1000 hertz. At every frequency, we determine which is the lowest level at which the patient can hear the sound. So the lowest level at 250 hertz was 10 decibel. Lowest at 500 hertz was also 10 decibel, 1000 was somewhere around 15, 2000 hertz it was at 10, and so on. So that tells us that the hearing threshold is least at 10 decibels. Then we have the bone conduction curve. The same way we do a testing at different frequency and determine the lowest threshold at which the patient is able to perceive the sound. So you see the air conduction curve and bone conduction curve. Both of them are lying below 20 decibels. They are here. They are lying between 0 to 20. None of the curves are falling down, which means that the patient's air conduction as well as bone conduction is normal, which means that the patient's conductive pathway and the sensory neural pathway are functioning normal. So in normal graph, you will see both the AC curve and BC curve. How do we know they are AC curve and BC curve? By the symbols. 0 stands for AC, lesser than stands for BC, which we have described. 0 stands for air conduction, lesser than stands for bone conduction of the right ear. So you can see here, they both are lying between 0 to 20 and they are not going below 20. So this is a normal graph. Now assume the patient has a conductive pathology. Will only air conduction be affected? But will the bone conduction be affected? No. So whenever the patient is having a conductive type of hearing loss, only air conduction is affected. Bone conduction is not affected. So let us see what happens in patients with conductive hearing loss. So you can see here bone conduction is normal because in conductive only AC is affected, BC is not affected. So you can see the BC curve is lying between 0 to 20. You can see here the BC curve at all the frequencies is lying between 0 to 20. But the AC curve is being affected. It is coming down below 20. So you have a gap between the BC curve and AC curve because in conductive pathology, AC will be affected, BC is not affected. So when you see a graph like this, a patient comes to you with an audiogram like this, where the bone conduction is affected, bone conduction is normal and air conduction is affected, then you should think that the patient is having some conductive type of hearing loss. Now the patient can come to you with a graph like this. 0 depicts your air conduction curve, lesser than depicts your bone conduction curve. You see, both the curves are not lying between 0 to 20. Both the curves are below 20, which means air conduction is affected, bone conduction is affected. So in which pathologies both will be affected? Obviously, it will be your sensory neural pathology. So when a patient comes to you with both the curves being affected, both the curves not lying between 0 to 20, then you should think that the patient is having a sensory neural hearing loss. So in your own clinic or in your own setup, you shall be able to understand if the patient is having a conductive type of hearing loss or a sensory neural type of hearing loss. If you know that, you would be able to understand where is the pathology, because when we talk of conductive hearing loss, we know the pathology is somewhere in your external ear or your middle ear. When we talk of sensory neural hearing loss, we know the pathology is somewhere at the level of your cochlea or your eighth nerve or the pathway that takes it to the brain. So this way we will know or be able to localize where is the problem. So if a patient with conductive pathology or a conductive hearing loss comes to you on tuning fork test, you have identified that, you probably will think, is there any disease of the external ear like a wax? Is there any infection of the external ear like otitis externa? Is there a hole in the tympanic membrane like a perforation? Is there any ossicular discontinuity because of which the sound is not being transmitted from malleus to incus? Is there any fixation of one of the ossicle by excessive bony deposition like otosclerosis? Is there any fluid accumulation in the middle ear, which we call it as middle ear effusion? So you will think of all these causes if you have got on your tuning fork test a patient having conductive type of hearing loss. On tuning fork test and audiometry, if you get a patient is having sensory neural hearing loss, you will not think of all these pathologies at all. You will think there is some pathology in the inner ear or the pathway behind it which goes to the brain. So you will think that there is a problem over here and you will try to rectify the problem over here. So there are various treatment options for a patient with hearing loss. The commonest being hearing aid. It can be used for those who have conductive hearing loss as well as sensory neural hearing loss. But when you have a conductive type of hearing loss, most often it is correctable. Like if you have a wax in the ear, you can remove it. If there is a hole in the eardrum, you can repair it. If there is a ossicular discontinuity, you can make a continuity. If there is a fluid in the middle ear, you can give medical therapies to resolve that. So they are correctable causes. So you can either treat it themselves or you may refer to a specialist. But most often, if there is an inner ear problem, they are not correctable. They can be treated either with hearing aids, they can be treated with implants. There are various modes of rehabilitation for patients who have a sensory neural hearing loss. We will understand different diseases of the ear, of the nose, of the throat in my further videos. Hope to see you all until then. Bye bye.